Welcome to this presentation called Delirium in Critical Care and Beyond. This presentation is intended for all of the rehab disciplines to gain a better understanding of delirium throughout the hospital. We are going to dive deep into the areas of delirium that were identified through the survey that was sent out a while ago. So let's get started. These are the learning objectives that I hope to accomplish with this presentation. We're going to start by looking at the background of delirium. What is delirium? In simple terms, delirium is characterized by a sudden onset, difficulty maintaining a stream of thought, poor reasoning skills, and impairments in psychomotor activity. This is how delirium is described by the DSM-5 criteria. So first, there's a disturbance in attention and awareness. Second, there's acute and fluctuating change in mental status from the patient's baseline. Number 3, there is an additional disturbance in cognition, such as memory. 4, disturbances are not explained by an established or pre-existing neurocognitive disorder, including coma. And 5, disturbance is a direct physiological consequence of a medical condition, toxin, or multiple etiologies. The CAM-ICU is typically utilized in critical care to determine whether a patient is experiencing delirium. There are 3 subtypes. Hyperactive delirium, which is what we typically think of when we think of delirium. So these patients are the ones that are agitated, combative, they're trying to get out of bed, they're usually restrained, their speech is disorganized, and typically they're experiencing hallucinations. Hypoactive delirium is characterized by drowsiness, decreased movements, they can't keep their eyes open and have trouble maintaining attention. And mixed delirium has characteristics of both hypoactive and hyperactive delirium. This subtype fluctuates a lot between the two. Delirium is a problem in the older adult population, but it also may be prevalent in younger individuals that are critically ill. In the critically ill patient population, one study found that 47 to 87% of all individuals admitted to critical care and intensive care units were experiencing delirium. In the general medicine patient population, another study found that 11 to 25% of older adults were experiencing delirium upon admission, and another 29 to 31% of older adults developed delirium during their stay. And this is a really high prevalence of this condition for patients in acute care. These are some common risk factors for individuals that are diagnosed with delirium. So for example, pre-existing dementia, low cognitive reserve, advanced age, high comorbidity burden, visual impairment, depression, alcohol abuse, malnutrition, and narcotic use. Here are some possible causes of delirium. And again, these include high illness severity, infections, dehydration, electrolyte imbalances, kidney and liver failure, withdrawals, seizures, nervous system dysfunction, cardiac dysfunction, pulmonary dysfunction, trauma, pain, medication, and being in an unfamiliar place. Usually there is many factors and causes behind someone developing delirium, and there's not just one reason. It is a multifaceted condition which makes it difficult to manage and treat. And just something interesting about medication and sedation, the development of delirium is almost certain with lorazepam doses that are greater than 20 milligrams per day. And lorazepam is a benzo. And so I think that this is something interesting to think about when we're chart reviewing our patients. If we see that our patient is receiving lorazepam or another benzo, then we can be aware of the fact that delirium will almost likely be present with this patient. And we can also use this information to advocate against the use of benzos with our patients. So is there something that we can recommend to the nursing staff or to the doctor to see if we can get their medication switched? So why should all of us care about delirium? Well, it is very common and has impacts at the hospital level and the patient level. At the hospital level, um, delirium is associated with an increased hospital length of stay and increased days on ventilation. Additionally, at the patient level, delirium is associated with increased mortality, decreased functional ability, and persisting cognitive impairment, even when they're discharged from the hospital. We should really be concerned about the decreased functional ability and persisting cognitive impairment. This is also where we might be able to make the biggest impacts. Our interventions target patient level factors most often, and we focus on the functional abilities of our patients. But through our interventions, we may also be able to influence hospital level factors too. Detection should occur early, often, and continue beyond critical care. There are many screening tools for delirium, and they include the CAM ICU, which is utilized throughout the Ohio Health System, assessment tests for delirium and cognitive impairment, are also known as the 4AT, the Delirium Rating Scale, or the DRS, Delirium Symptom Index, the DSI, Intensive Care Delirium Screening Checklist, or the ICDSC, the Memorial Delirium Assessment Scale, MDAS, and the Simple Query for Easy Evaluation of Consciousness, the SQEEC. So delirium has no cure. So the literature suggests that prevention is the best way to manage delirium. As noted in the epidemiology slide, delirium is not limited to the intensive care unit. Especially in older adults, delirium may be present throughout their entire hospital stay. And the CAM ICU is a popular assessment and has good results in validation studies. However, this screening tool might not be the best to use throughout the entire hospital. And I think it's important to think about if we could possibly use just the regular CAM generalized screen or be able to implement the CAM ICU out of critical care because it is um, a simple screen that is quick and easy to use. And so we're going to dive a little bit deeper into some of these screening tools. So I just wanted to include this slide to explain some of the things that I'll be discussing with each one of the screening tools. So first is reliability, which is going to consider the repeatability, human impact, alternate forms, and consistency of the tool. We're also going to look at Cohen's kappa, and that measures rater reliability by assessing the agreement between the raters. And that's looking at the an almost perfect agreement is between 0.81 and 1. Next is validity. And so for internal validity, how we're looking at how sure we are that the independent variable caused the dependent variable. Whereas external validity looks at how are we sure that the findings are generalizable to a bigger population. We also look at measurement validity, which is how sure are we that the score measures what it's supposed to measure, which will be important for looking at screening tools. Next is sensitivity. And so that's looking at and it means it's the true positive rate. So a high sensitivity means that the tool correctly identifies patients with a specific disease. On the other hand, there's specificity, which is the true negative rate. So a high specificity means that the tool correctly identifies patients who do not have a disease, and that means there will be few false positives. So first we're going to look at the CAM and the CAM ICU. There are other variations of the CAM that are similar, such as like the family CAM, the basic CAM, and just the normal CAM. And we're just going to focus on the CAM ICU because it's already being used at Grant and within the Ohio health system. And I think we should think about implementing this with patients outside of critical care because it's simple and already being utilized. If a patient is on the general med floor or something and was previously in critical care, this tool may be used to help create some consistency in delirium care across the continuum of their acute care stay. So, just going a little bit deeper, this tool has 4 items, um, and those include acute onset of mental status changes or fluctuating course, inattention, disorganized thinking, and altered level of consciousness. This tool should be administered by a trained clinician and utilizing the ICU CAM variant with a mixed population of critically ill patients. So it's you can use it with it's not specific to a certain diagnosis. Some implications for practice I found, and it's a quick assessment with only 4 categories that only include yes or no options. So if your patient's intubated, they don't need to talk. The reliability in the Cohen's kappa is 0.96, which is really close to that almost perfect 1. Your sensitivity is 80% and specificity is 95.9%. Okay, and here's the CAM ICU flow sheet. And us as therapists, we're able to document the CAM ICU if we administer it in the flow, I think it's the complex assessment tab in the flow sheet within Care Connect. And I really would encourage you to read up on the CAM ICU and get some training on it and to be able to implement it during your sessions. Like I said before, it's really quick. Usually takes less than 2 minutes. So think about how you might be able to add it to your orientation questions when you're asking those to the patient. And each patient's score on this will help to inform your treatment and establish appropriate outcomes. It's a great tool to use, so don't be afraid to implement it with your patients. The next is the 4AT assessment test for delirium and cognitive impairment. And this tool utilizes 4 items based on the DSM-4 criteria for delirium. It assesses alertness, orientation, attention, and acute fluctuating mental course. It can be quickly administered to a mixed population, again, not specific to one diagnosis, in about 2 to 3 minutes, and this can be done by anybody. A score of 4 or above determines possible delirium with or without cognitive impairment. And so, some implications for practice is that it assesses orientation by asking the patient their age, date of birth, and the place that they're in now and the year. It assesses attention by asking the patient to say the months in backwards order. This may be difficult to implement with critically ill patients due to the amount of talking required to complete this assessment. The reliability is 0.8, the sensitivity is 89.7, and the specificity is 84.1%. And this is the scoring form for the 4AT. As you can see, it assesses alertness, orientation, attention, and acute change or fluctuating course. Note that this can be used to determine delirium and or cognitive impairment. 0 means unlikely delirium or cognitive impairment. 1 to 3 is possible cognitive impairment, and 4 or above is possible delirium and possibly cognitive impairment also. So next is the delirium rating scale, or the DRS, and this tool has 10 items that are based off the DSM-3. Administration takes a little bit longer at about 20 to 30 minutes. It can be utilized again with a mixed population and requires psychiatric specific training. The items are temporal onset of symptoms, perceptual disturbances, hallucination type delusions, psychomotor behavior, cognitive status during formal testing, physical disorder, sleep wake cycle disturbance, lability of mood, and variability of symptoms. Again, so some implications for practice is that this scale assesses 16 areas of patient functioning to provide a holistic look at delirium. It assesses perception, affect, memory, motor, language, sleep wake cycles, visual skills, orientation, and more. The reliability here is 0.92, sensitivity is 91%, and specificity is 80%. Next is the delirium symptom index, and this tool is an interview where questions are based on the 7 symptomatic domains of delirium. And this tool is to be used with a population of people that are 65 years or older in the medical surgical unit. And there's pretty limited evidence on the utilization of this tool. But some implications for practice are that it assesses the delirium by asking patients questions and observing their behavior. The questions are categorized by orientation, sleep, perception, speech, psychomotor, consciousness, and behavior. May not be appropriate for critically ill patients who are intubated. Again, and it also needs to be used with patients that are older than 65. The reliability here is 0.92. Sensitivity is 91%. Specificity is 80%. So the next is the Intensive Care Delirium Screening Checklist, or the ICDSC. And this tool has 8 items that are based on the DSM criteria for delirium also. These items are altered level of consciousness, inattention, hallucination, delusions, psychosis, psychomotor agitation or retardation, inappropriate speech or mood, sleep-wake cycle disturbance, and symptom fluctuation. And this tool, again, can be used with a mixed population, so not specific people are excluded from this symptom screen. So looking at implications for practice, it assesses additional areas of patient functioning to provide a big picture of delirium. These areas include orientation, hallucinations, psychomotor, speech, mood, and sleep. And again, it may be appropriate to administer to most critically ill patients due to the decreased need for speech throughout. The reliability here is 0.947. Sensitivity is a little bit lower at 74%, and specificity is 81.9%. And so here's the scoring form for the ICDSC. Again, this one looks at more factors than the CAM-ICU. And so think about all the information that you could gather from utilizing this tool about your patient's symptoms. Okay, next moving on to the Memorial Delirium Assessment Scale, the MDAS. So this tool is a 10-item scale based on the DSM-4, and it's typically performed by a physician to screen for severity of delirium. Administration should take about 10 minutes, and items include aspects of arousal and level of consciousness, cognitive function, and psychomotor activity. So some implications for practice here is that it assesses patient function and cognition through 10 items that include awareness, orientation, short-term memory, digit span, attention, thinking, perception, delusions, psychomotor, sleep-wake cycles. And the impaired digit span section says rate current performance by asking subjects to repeat the first 3, 4, then 5 digits forward, and then 3, then 4 backwards, then continue to the next step only if the patient succeeds at the previous one. Some sensitivity here is 64.1, and specificity is 100%. And this is the scoring form. So as you can see, this is a lot more in depth than like the CAM-ICU or the 4AT. So think about what section could be implemented to gain a deeper understanding after you see some red flags during like a CAM-ICU assessment. The simple query for easy evaluation of consciousness, or the SQEEC. This tool has two items that are presented in a narrative interview form based on DSM criteria. And this limits the critically ill population with varying levels of consciousness and patients who are intubated. Some implications for practice is that it assesses cognitive processes and disorganized thinking through asking open ended questions. First is imagine that you are well, name a place that you would like to go to that you have never been before. The second question is how would you make the journey? Additional follow up questions would be how would you organize the trip or the flight? And will the plane fly through water? And the tool is adapted to answer. So if a boat trip is chosen, then will a boat float through the air? And that question would be implied instead. Again, this tool may not be as appropriate for critically ill patients that are intubated. The sensitivity here is 83% and the specificity is 81%. While it may not be feasible to implement any of the aforementioned screening tools in a standardized manner, except for like the CAM ICU, think about how we might be able to gather information on how an individual is experiencing delirium with some of these tools. And so these tools can help us to gain a deeper understanding or insight into our patient's unique delirium and how we can best assist them in performing functional tasks. If we find that they're having a more difficult time with specific areas, we can better target our interventions and promote participation in tasks. So, for example, if you find that they have disorganized thinking on the CAM, you can find that they have sleep wake cycle disturbances with like the MDAS or ICDSC. You can find out some memory issues with the MDAS and inattention with the CAM and with the ICDSC. And like I said, we can better target our interventions and better look at how they are functioning in each one of these specific areas. And so these are the areas that I found doing my research on OT's role specifically. However, I think it is safe to say non pharmacological management of delirium is within the scope of all rehab clinicians to a certain extent. So, the non pharmacological treatment that I targeted for OT is early mobility, sensory stimulation and sleep, positioning, cognitive retraining, upper extremity function and preservation, as well as basic ADLs and family and caregiver involvement. I'm going to go more into more depth with three of these interventions that I believe will be the most relevant to the entire team. So first we have sensory, and this is one of the non-pharmacological areas, obviously. And we want to look at environment, the person, and the sleep. So environmental interventions include, lights on, blinds open, music playing, or TV on, and think about writing orientation information somewhere where the patient is able to see it. Another sensory intervention idea may be applying interventions to facilitate a response from the person. And these interventions may include noxious stimulation, such as pinching different parts of the body to facilitate a response, and if the response is different on different areas. Pressure to the nail bed. And so thinking about like loud claps and things like that too, to apply some of that noxious stimulation to the person. More interventions to facilitate responses are providing visual interventions, such as scanning and tracking bright colors, auditory stimulation, which may include, like I said, loud claps or saying the patient's name very loud. We can also promote sleep wake cycles through collaborating with the interdisciplinary team. Some interventions utilized in pediatrics to provide input to the body is brushing and joint compression, as well as like muscle belly rolls. And I was unable to find much evidence on these interventions for the adult population. So it may not be the most evidence-based practice, but it could be utilized to promote proprioceptive and tactile input to the body. I just want to emphasize that you're going to use these interventions with caution and watch out for precautions or contraindications with our patients. A good resource for tactile and proprioceptive sensory input for adults is the JFK Coma Recovery Scale, and it provides really good sensory interventions, even if you're not utilizing it as an assessment. So I definitely would encourage you all to look into that too for sensory interventions. For cognitive interventions, we want to focus on all of these things here. So engagement, social interaction, orientation, and higher level cognition. So, how is their engagement? Are they alert and aware to what's going on around them? Are they engaged with the environment? Are they engaging with you as a therapist? Think about ways that you can facilitate their engagement. And this could be even done through the simplest things, such as like just talking to the patient and changing up their environment. Next, looking at how is their social interaction? Are they making eye contact with me or anyone else in the room? Are they answering questions appropriately? Are they following your commands? Um, think about ways you can provide that social interaction that all humans need and that they may not be getting when they're in the hospital. So, providing that meaningful touch, talking to them and not at them. And so next we're looking at how is their orientation. So we're going to ask orientation questions, provide orientation. You can give choices or cues. And are they able to see the orientation information in their room? And if not, how can we rearrange the space or what we can provide to make sure that they're oriented at all times? Again, and then the last one is to challenge their higher level cognition. So for our higher level patients, we can provide them with puzzles or having them sequence through tasks. And the last intervention we're going to look at is family and caregiver engagement. So we should always be engaging the families whenever possible. We can facilitate education and involvement of families and caregivers. All of us can do this. And we can educate through providing training on delirium, explaining your specific role in their um, medical healthcare team. And you can also go into the family's role in reorientation and explaining the importance of that to them. Can encourage them, the family, to bring in pictures and or familiar objects for the patients too. We can involve families through our plan of care, determining the patient's goals, gaining essential patient information, and encouraging them to be involved in social interaction with their family member. We can also encourage them to bring in glasses, hearing aids, dentures as needed. And so a question I got from the survey was, what types of cues should I be giving? And so, like I said, this was a question asked in the survey, and I'm not quite sure what the correct answer is, and I don't know that I have it. And there's not a lot of information in the literature about the best kinds of cues. I think it is important to be client centered and giving the client what they need and giving the patient what they need and kind of meeting them where they're at. But I think it's important to be mindful in the cues that we are giving. So when providing tactile cues, we want to increase attention and awareness to an area of the body or to a specific task. So if we want the patient to move their right arm, think about providing tactile cues to that arm. To facilitate a response, we can provide deep pressure to the muscles and perform, like a sternal rub or something like that. When providing verbal cues, we want to make sure that our cues are simple and direct, especially to these patients that are experiencing delirium. And so we want to remember that these patients are already confused. We don't want to give them too many cognitive challenges initially. We want to make sure that we are leaving enough time for the patient to respond. So giving them a couple seconds in between what we're telling them to do. And so whether it be a verbal response or a response to stimulation, we want to give them that time to respond. And for me personally, I tend to just talk and talk and talk to patients. And I'm not comfortable in in the time waiting for a response. But with these patients, it may be beneficial to allow some time for a response. So we might be a little uncomfortable, but we don't want to be overstimulating our patients and not giving them enough time to show us that they can understand what we're saying. And then this is just something that I thought was very interesting, and I found a video on and just some literature on. And it's a good method, I think, for managing cues with agitated patients specifically. So this is called the TADA method. The first, and it's an acronym. So the T is tolerate. We want to tolerate these seemingly dangerous behaviors to allow patients to respond naturally and provide them with some control over their circumstances. So, for example, getting out of bed might mean that they need to go to the bathroom. So, how can we help facilitate that to tolerate this behavior? The next is an A, and it's anticipate. And we're anticipating an educated guess on what the patient might do and how to avoid advancing agitation. So, for example, here, can we make sure that we are ambulating patients and providing engagement to decrease their wanting to get up on their own? And then the DA stands for don't agitate. And this is the golden rule of this approach. We want to avoid agitators when possible. So, reorientation may worsen agitation if you're constantly reminding this person that what they're thinking is wrong and they're not at home. And so, it might just put a strain on that therapeutic relationship. So, if you notice that that's something that's making your patient more agitated, then maybe we don't do reorientation. But a big thing with this method too is we want to make sure that the patient is still staying safe. So we want to make sure that there's someone in the room just in case they do get up, they don't fall, things like that. So just something to take into consideration and something to think about how we might be able to use bits and pieces of this method to decrease agitation with our patients. So, something that I noticed too with the surveys was documentation. So, how should we be documenting the management of delirium? We want to document what we did, what specific strategies were utilized, the patient's response, and what we recommend moving forward. So, do you guys remember SOAP notes? We want to make sure that we're using and including the OAP part of SOAP into our notes to document delirium. So for the O, that's objective. So that's what we did during the session to target delirium. The A is assessment and how we evaluate how the patient responded to the interventions. How do we know, that it worked or how did the patient respond? What were they doing to respond? And the P is plan. So what would we recommend for next steps or to continue with delirium management with this patient specifically? So with that being said, um, some of our interventions we may be documenting in areas of the flow sheet, um, such as like cognition and mobility and things like that. But are we saying that it was done for delirium management or what was the purpose? We here want to document what we did, what specific strategies were utilized, the patient's response, and what we recommend moving forward, kind of like I mentioned in the previous slide. And due to the multifaceted nature of delirium management approach, documentation may be occurring in other areas of the flow sheet, like I mentioned before, but it might not be specifically targeted at delirium. And so I created a rehab delirium smart phrase. And I created this to better document all of these interventions within this like delirium management lens. And so the idea here is that we can look at each other's notes to determine what strategies were effective in managing delirium and what strategies were not. Are there things that we should try next session, or can we use this documentation to see progress in how our patients are responding to the delirium interventions? And below here is a picture of the smart phrase. And we will walk through each option that you need to fill in or that choices that you'll be given. Okay, so first we need to choose whether we are preventing or managing delirium. So I like to think about prevention as actionable steps that were taken to decrease the risk um, for the patient to develop delirium. And I like to think of management as the patient was previously showing signs or symptoms associated with delirium and or they have a positive score on the CAM ICU. So, and we want to remember that when we are administering the CAM ICU, we're not diagnosing delirium. Okay, so the next part are the main non-pharmacological interventions that were utilized in the session. So, for example, did you only implement sensory, cognitive, positioning, and mobility interventions? Then those are the things that we're going to choose from the drop-down list over here. So, everything in the drop-down list was the interventions that I found from my research, which is why I included the 3 asterisks at the bottom. If there are other non-pharmacological interventions found in the literature for other disciplines, then you may want to add that there. So here we're looking at non-pharmacological treatment strategies for the next part. So the specific strategies that you implemented in the session, and this is think about the skilled intervention that you did. So these are kind of under the umbrella of the bigger interventions that were chosen previously. So again, the specific interventions and what you facilitated throughout the session to address delirium within the framework of the larger intervention. So, for example, here you would type, provided reorientation, facilitated simple grooming task, raised head of bed, position fingers into extension with the use of a rolled washcloth, provided simple upper extremity or lower extremity exercises for the patient to perform in bed. Okay, and next we're looking at how the patient responded. So, how did the patient respond to those specific interventions that you implemented throughout the session? And so that's what we want to document here. And we want to use clinical judgment to determine the proper choices. So, again, looking at it, it says excellent, good, fair, poor. I don't know if we'd ever use really excellent, but if you see like a very big, considerable change, then maybe that's when you would choose excellent. But for here, I would say good would be changes were noticed in the patient and their performance was greatly improved. If you're choosing fair, I would say that there were few changes were noticed in the patient and their performance may or may not have improved in the tasks that they were presented with. And the last one, poor. I would say that no changes were noticed and there was no improvement in performance. Okay, and this is the patient response rationale. So here you're just rationalizing your previous statement. And this choice made more sense when we move on to the next slide, but you're just kind of saying like they demonstrated good, fair, or poor response to non-pharmacological delirium strategies as evidenced by what? Was something increased, was something decreased, or was there no change in? And again, like I said, it'll make more sense when we move on to the next slide. And here we're just continuing to rationalize the patient response. So what responses did you see occur to justify the patient had a good, fair, poor response to intervention? And how did you know that your intervention was working? So what did the patient specifically do? For example, you could say increased alertness, increased eye opening, increased orientation, or decreased agitation, or increased agitation. I provided choices, but again, there's also the 3 asterisks to add any other things that you may notice improvement in or decreased functioning in. Okay, and then moving on to your recommendation. This is just The first part is just identifying yourself. So are you a PT, an OT, or an SLP? And then continuing on to the rest of your recommendation. So think of this as part of your plan for the patient as mentioned above or in the previous slide. So what would you recommend for the interdisciplinary team to continue to carry out in next sessions? And what about your coworkers in the same discipline? What do you want them to know what worked, what didn't work, so they can help carry over these interventions? And again, I provided some choices, but again, there might be more choices than what was listed. So feel free to use the 3 asterisks to add additional recommendations here. Okay, and how can we carry over these interventions and this information about delirium beyond critical care? So I think it's important to understand how our patients are being affected by delirium, being overlooked and not considered outside of critical care. Informal or formal screens. Remember that we can't diagnose delirium, but it is important to have a good idea of where our patient is struggling and what outcomes we may want to utilize. Think about how interventions that you normally implement are affecting the patient and their delirium. We need to make sure that we are advocating for the non-pharmacological management of delirium to the interdisciplinary team, to patients, to other clinicians. Is it that the patient isn't following commands, or are they just not engaged in their environment? Are they agitated because they are not engaged? And like I kind of mentioned in the tada method, are they trying to tell us something, but they're too agitated to communicate that? Like they have to go to the bathroom, so they're trying to get out of bed, things like that. And so think about some of these concerns and bring it to the team if needed. Collaborate with other rehab team members too. So, for example, is speech consulted for a patient that would benefit from more cognitive retraining interventions than like us as OTs would be able to provide, or than a PT would be able to provide? I think it's important to utilize each other in our different scopes of practice. And so, looking at carryover for nursing, I think it's important to advocate for your role and for non pharmacological management. Present evidence and literature to make these points more clear to the nursing staff and to the interdisciplinary team. But if we are not confident and cannot explain our purpose or role in this space, then will be difficult to advocate. I also think it's important to ask questions to find out why, you know, the interdisciplinary team doesn't believe that the patient is appropriate for therapy. So I think it's important to be clear on the interventions that you are providing and why. I've created delirium specific handouts and a presentation on OT's role in delirium, as well as a delirium checklist and additional interventions. So use these to assist your interventions as well as making nursing staff aware of these resources or the resources that you are implementing with the patients. And I think a big part here is like consultation. So be a resource for nursing staff to consult with on these issues. They spend the most time with our patients. We should make them feel comfortable to consult with us about delirium, encourage them, and continue to build rapport in this way. Ultimately, I wish I had the answers to increase carryover and decrease utilization of sedation and restraints. But I think conversations and receiving education on topics um, we are not as informed about and nursing might not be as informed about are big. I also think ask questions on why restraints are needed for heavily sedated patients, like, for example. So if our patient's heavily sedated, do they really need um, restraints, or kind of dig a little bit deeper into some of these questions. And I think it's important to attend um, meetings and things like that on delirium when possible and when you're able to. And I recently attended delirium rounds that came back after COVID. And it was such an eye opener, and I learned so much from other um, work like nursing and the interdisciplinary team. So keep your eyes open for opportunities like that to help with education. And all of these things to assist in carry over. One question asked during the survey was about COVID-19 and delirium, and there's a lot of information and literature on this topic, and there's even more than I thought there would be, which is pretty cool. Literature tends to focus on older adults due to their risk for COVID, for both COVID and delirium. So 37% of older adults presenting to the emergency department had delirium as their primary COVID symptom. And I think that's so interesting. Um, yeah, like similar to delirium being present in urinary tract infections with older adults, they have found that many confused patients with no other symptoms were showing up to the hospital and testing positive for COVID. Next, patients with COVID may be at an accelerated risk for delirium. So many factors may be responsible for high rates of delirium with COVID patients, including decreased social interaction and decreased mobility. Delirium is common and associated with functional impairments. So in older adults with COVID-19, delirium is associated with increased mortality. Delirium has also been found to be underdiagnosed during this time. And we already know that delirium is associated with functional impairments, so we need to be managing it now with COVID too. So those are some of just the main points that I found from the literature. And so I think some of the main takeaways from the literature and from that information in the previous slide is that COVID-19 patients have delirium too, which means that there is a need for continued delirium management with these patients. We should use the existing literature to advocate for the appropriate delirium management measures to be taken with the COVID-19 population. Delirium prevention is even more important now, and programs should not disseminate despite challenges with COVID-19. And I personally am so glad that things like delirium rounds are coming back because delirium is so prevalent even now, and we should be continuing to manage and prevent it. All right. So, in summary, delirium affects a lot of patients in critical care and beyond. Remember, delirium does not stop in critical care. Screen often and promote prevention. Screening will help to recognize signs of delirium in our patients and promote prevention with our patients to stop delirium before it starts. Non-pharmacological treatment is effective. The risk of developing delirium is higher for patients not receiving non-pharmacological treatment. Advocate for your role in this space and assist in collaboration with nursing to increase carryover. Reiterating that delirium is common with COVID. And last, keep doing what you're doing. A lot of the recommendations in the literature are things that are already occurring in our therapy sessions and programs that are being implemented by Grant and Ohio Health. So thank you so much for listening to this presentation. I hope you found this information useful. Here are all the references for my project if you are interested in learning more.